Thank you for inviting me to present data on the clinical phenotypes and outcomes in carriers of truncating variants in the Filamin-C gene. My name is Mohammed Majid Akhtar. I'm a cardiology registrar and clinical research fellow based at the Bart's Heart Centre in London and University College London. As you will be aware, dilated cardiomyopathy has a population prevalence of 1 in 250. It is associated with considerable morbidity and premature mortality, and it's the commonest cause of heart transplantation worldwide. Previous studies have shown that as many as 4% of cases of genetic dilated cardiomyopathy are related to truncating variants in the Filamin-C gene. The cardiac myocyte contains many important proteins, including sarcomeric proteins, nuclear envelope proteins, cytoskeletal and desmosomal proteins. We know that mutations in genes encoding these proteins are strongly associated with cardiomyopathy. Filamin-C is no different. As demonstrated in this cartoon, Filamin-C is an actin cross-linking protein that is highly expressed in striated muscle and is located at the myofibrillar intercalated Z disc. Previous work by Ortiz-Genga et al. Has shown evidence of fibrosis both on post-mortem studies as well as on cardiac magnetic resonance, and demonstrated associations with ventricular arrhythmia and sudden cardiac death. What was the aim of this study? Well, the aim of the study was to get a further insight into the clinical phenotype of filamin carriers, understand longitudinal data on their clinical phenotype, as well as outcomes associated with these mutations, and to compare patients who carry these mutations against the commonest cause of genetic dilated cardiomyopathy, i.e. titin. Patients were recruited from 19 centers based at 5 European countries, and all patients had baseline visit to our centers between 1990 and 2018. Both probands and relatives were incorporated into the cohort. We used a rarity cutoff of less than 1 × 10⁻⁴, or a novel gene mutation that was pathogenic in the Filamin-C or in the titin gene to incorporate our patients into the cohort. We use nonsense, frameshift, canonical splice site variants, and large gene deletions. Patients who had more than 1 pathogenic or likely pathogenic gene implicated in DCM were excluded from the analysis to minimize the impact of compound mutations. All patients had baseline clinical assessment, 12-lead electrocardiogram, as well as echocardiographic data analyzed. In those that were a smaller cohort of patients that had cardiac magnetic resonance and Holter data available, these were also collated. All patients were followed up as per usual clinical visits. We defined impaired left ventricular function as the presence of an ejection fraction of less than 50%. And we then further refined this into 2 groups, into those with mild to moderate left ventricular systolic dysfunction, and those with an ejection fraction between 36 and 49%, and those with severe left ventricular dysfunction, and those with an EF of less than or equal to 35%. We also realized that there were patients who had evidence of a cardiac phenotype without evidence of left ventricular dysfunction. In these patients, we looked for a minor non-diagnostic phenotype that suggested that there was evidence of gene expression. This could include the presence of isolated left ventricular dilatation, an abnormal ECG with T-wave inversion, atrial arrhythmias, ventricular arrhythmias, or even fibrosis on CMR. Our primary endpoint was a composite or combined endpoint event of malignant ventricular arrhythmia, as well as heart failure endpoints. The arrhythmic endpoints included patients having sudden cardiac death, an aborted sudden cardiac death, appropriate defibrillator shock, hemodynamically stable sustained VT, or anti-tachycardia pacing for ventricular tachycardia in those with a device. Heart failure endpoints included the presence of heart transplantation, end-stage heart failure mortality, or destination ventricular assist device. We also analyzed an isolated arrhythmic endpoint, which did not count for heart failure endpoints. So moving on to the results. Well, we initially identified 175 carriers with truncating variants in the Filamin-C gene. 8 patients had to be excluded because they presented with sudden cardiac death or a surrogate, and so we lacked any baseline ante-mortem data. These patients were identified to carry mutations on post-mortem molecular autopsy. This left us with 167 patients with longitudinal data who had truncating variants in the Filamin-C gene. These were roughly divided into 1/3 of whom, which were 55 patients who were probands from 61 families, and the remainder of whom were relatives. There was a roughly equal sex distribution between male and female in this cohort. This cartoon shows the location of the different genetic mutations across the Filamin-C gene in both the nonsense frameshift mutations on the top, as well as the canonical splice site variants at the bottom. And you can see that the mutations are distributed across Filamin-C. So what are the clinical phenotype of carriers of filamin mutations? Well, the first thing is when we look at the familial history of dilated cardiomyopathy, we find that 64% of patients had a family history of DCM. Over 50% of patients had a familial history of sudden cardiac death, and 29% of patients had a multiple family history of sudden cardiac death. Although dyspnea was a commonest presenting symptom, palpitations were also frequent in almost 22% of the cohort. NYHA class 3 to 4 dyspnea was only present in 10% of the population. ECGs were frequently abnormal, with abnormal T-wave inversion noticed in 28% of the patients at baseline evaluation, and low voltages on the QRS in the limb leads in 22%. In terms of arrhythmia, AF was present in 4% of the cohort at baseline evaluation, but there was a significantly higher prevalence of ventricular arrhythmias, with 32% having non-sustained VT and 40% having frequent ventricular ectopics, being more than 500 in 24 hours. When we assess the spread of left ventricular ejection fraction in the cohort, we can see that probands had a significantly lower left ventricular ejection fraction than relatives, and that males and females had similar spread of LV ejection fraction. We also noticed that the frequency of ventricular ectopics, or the burden of ventricular ectopy, increased progressively with progressive severities of LV systolic dysfunction. Importantly, when we look at cardiac magnetic resonance data, what we notice is that over 1/3 of patients with normal left ventricular ejection fraction had evidence of fibrosis on cardiac magnetic resonance. This increased to 80% and 83% in those with mild to moderate or severe left ventricular dysfunction, respectively. What's also important is that we noticed that there were patients who had LV systolic dysfunction despite the absence of fibrosis on cardiac magnetic resonance. What about the longitudinal follow-up of these patients? Well, when these patients were initially assessed at baseline evaluation, we know that around 43% of the cohort had evidence of a cardiomyopathy. In the remainder, 57%, these were roughly equally distributed in those that had no evidence of a cardiac phenotype whatsoever and were labeled as phenotype negative, or they had evidence in the other half of having a mild non-diagnostic phenotype, but with preserved left ventricular function. What's interesting is over a median follow-up of 20 months, what we notice is that 13 patients transitioned to a different group. And importantly, 11 patients developed left ventricular systolic dysfunction over follow-up, and 2 patients started developing signs of gene expression when they previously had no evidence of a phenotypic expression. So what were the outcomes of these patients? Well, when we look at the number of primary endpoint events, we first look at the distribution of LV dysfunction at baseline evaluation. In the 70 patients that had LV systolic dysfunction at baseline evaluation, the overwhelming majority of primary endpoint events occurred in this group, in 25 endpoint events in this group. We know that one patient, we didn't have the actual LV ejection fraction at baseline evaluation, but they went on to develop an endpoint event, and we know that they had evidence of a clear cardiac phenotype on postmortem evaluation. In the 96 patients that did not have any evidence of LV systolic dysfunction at baseline evaluation, 3 of them went on to develop a primary endpoint event, all of whom had developed LV systolic dysfunction or a clear cardiac phenotype on follow-up. So we had 29 primary endpoint events That was either heart failure or arrhythmic endpoint events, so 17.4% of the cohort. And the majority of these endpoint events were due to arrhythmic endpoints, and 2/3 of these endpoint events were arrhythmic. Arrhythmic endpoints were predominantly driven by sudden cardiac death, with a roughly equal spread of aborted sudden cardiac death, appropriate defibrillator therapy, or sustained VT. In the heart failure endpoints, we noticed a majority of these were due to heart transplantation, reflecting the tertiary nature of the cohort, as most of these were tertiary cardiomyopathy referral units. Importantly, 5 patients had multiple endpoint events over this 20-month follow-up. Now, this Kaplan-Meier curve demonstrates freedom from the primary endpoint, stratified according to the baseline LV systolic function. And what we do notice here is that in this group of patients, if you had any degree of LV systolic dysfunction, you had reduced survival from the primary endpoint compared to the presence of preserved left ventricular function. Importantly, when we focus on the arrhythmic endpoint, what we notice is that patients with mild to moderate or severe LV dysfunction, so the red and yellow lines respectively, had evidence of a similar rate of endpoint events. In fact, this was statistically not significant with a p-value of 0.64, suggesting similar event rate in both groups. Now, one might argue that patients that had mild to moderate LV dysfunction were developing arrhythmic endpoint events because they just progressed in the nature of cardiomyopathy and developed severe left ventricular dysfunction. Well, this table was to look at the contemporaneous assessment of ejection fraction surrounding the time of the arrhythmic endpoint event. Now, this table initially, you can see here, shows patients having severe left ventricular dysfunction fitting with the time of their arrhythmic endpoints. However, this next table shows patients who had mild or mild to moderate LV systolic dysfunction developing these endpoint events. Again, this other table summarizes even more patients who had mild to moderate LV systolic dysfunction developing arrhythmic endpoint events with ejection fractions of 45, 40, 48, 40, and 40%, highlighting that actually contemporaneous assessment of ejection fraction was showing that patients in the mild to moderate cohort were still developing arrhythmic events despite the presence of less than severe LV dysfunction. Now, what about Titan DCM? How does Filamin compare to Titan DCM? Well, we used from the same center, we recruited 244 patients with truncating variants in the Titan gene and dilated cardiomyopathy. We compared this against 69 patients who had truncating variants in the Filamin-C gene with dilated cardiomyopathy at baseline evaluation. What do we notice? Well, first of all, Titan carriers were more likely to be male. They were more likely to be dyspneic at baseline evaluation or have atrial fibrillation at baseline evaluation. They also had longer PR intervals, although within normal limits. Filamin carriers, however, conversely, had a stronger familial history of sudden cardiac death and multiple sudden cardiac death. Furthermore, when we looked at structural abnormalities, these were much more common in the Titan cohort, with larger left atrial dimensions in the Titan cohort, which obviously fits with their more frequent evidence of atrial fibrillation in Titan. They had lower left ventricular ejection fraction on echocardiogram and RV function on echocardiogram. Filamin carriers, however, had lower QRS voltages under ECGs. They were more likely to have frequent ventricular ectopics under 24-hour Holter, and they were more likely to have fibrosis on cardiac magnetic resonance. Now, when we look at this Kaplan-Meier curve comparing the different cohorts, if we compare the blue and the yellow line, the yellow being patients with mild to moderate LV systolic dysfunction and Filamin mutation compared to Titan counterparts with similar ejection fraction, you can see that they have many more arrhythmic events than Titan cohort, which is statistically significant. What about patients that had severe LV dysfunction at baseline evaluation? So when we compare the red and the purple lines, again, we can see that patients with Filamin mutations had, again, significantly more arrhythmic events than Titan patients from baseline evaluation, even though they both had severe left ventricular dysfunction. So in summary, what has the study shown? Well, we can see that truncating variants in the Filamin-C gene are associated with malignant ventricular arrhythmia. Patients have frequent ventricular ectopics and non-sustained VT on Holter, and these are more frequent than their Titan counterparts. There's a very strong and high prevalence of familial history of sudden cardiac death or multiple sudden cardiac death, and that 2/3 of the endpoints in filament carriers were due to malignant arrhythmia. 21% of relatives also had evidence of impaired LV function at baseline evaluation, highlighting the importance of cascade genetic screening, as well as clinical familial screening to identify those at risk. Myocardial fibrosis was common in patients with filamin, much more frequent than their titin counterparts. And remember, over a third of patients with normal LV function at baseline ejection fraction had evidence of fibrosis. We know that on univariable analysis, fibrosis was associated with a primary endpoint. Is this a predictor of sudden cardiac death? Unfortunately, we weren't able to tell because the study was not powered to look at that, although we do know that fibrosis is not ubiquitous in those with severe or impaired LV function. Lastly, malignant arrhythmia do occur in patients with ejection fraction of greater than 35%. There was similar arrhythmic survival in those with mild to moderate and severe LV dysfunction. And when we look at contemporaneous ejection fraction into the event, we see that frequently patients had mild to moderately impaired LV function. Importantly, we know that arrhythmic events were much more common in filament carriers than their titin cohorts, despite the presence of similar LV function. This is a list of all the authors who were involved in the study. Without his help and expertise, this study would not be possible. And this is a list of all the sources of funding which helped facilitate the study. Thank you very much.